A very good day to one and all. So today's session starts with splinting. A splint is defined as a rigid or flexible device that maintains in position a displaced or movable part. For splinting, the ideal characteristics of a splint is it should be easily fabricated in the mouth without additional trauma, passive unless orthodontic forces are intended. It should allow physiological mobility and it should be non-irritating to soft tissues. It does not interfere with occlusion. It allows endodontic access and vitality testing. It should be easily cleansable or easily cleansed, easily removed. So instructions to a patient who are already having a splint or if you're planning to give a splint to after a traumatic dental injury. So these are the instructions you should give a patient whom you have given a splint. Consume a soft diet. Avoid biting on splinted teeth. Maintain meticulous oral hygiene. Use chlorhexidine or antibiotics if prescribed. Call immediately if splint breaks or loosens. So splinting is ideally given. Replanted tooth with mature root is ideally given for around 1 week. So this is the time period how long you should give a splinting. So in a replanted tooth with a mature root formation, you have to give splinting for around 1 week. Whereas in cases like tooth displacement, intrusion cases, extrusion cases, labial, lingual, or lateral displacement, and even in a mobile teeth, the splinting is usually given for around 3 to 4 weeks. Whereas replanted teeth with immature root, we are supposed to give splinting for around 3 to 4 weeks. Whereas for a mature tooth, you have to give for around only 1 week. But in case of a root fracture case, splinting has to be given for 8 to 16 weeks in order to heal the complete root and dentin everything. So this is one of the example, one of the most recent advances in the splinting, that is titanium trauma splint. The titanium trauma splint is made of pure titanium and is only 0.2 millimeter thick. It is easily adaptable to the contour of the dental arch. So here, as you can see, it is a rhomboid shaped splinting thing which you can easily etch and bond through this rhomboidal space. You can bond and use a resin material to fix the splint, and it's easily applied and you can remove it very easily. So it allows physiological tooth mobility without transferring orthodontic forces to the splinted teeth, and the rhomboid openings of the splint which facilitates its fixation. A small area of bonding, thereby reducing the amount of composite to be used. It is no longer necessary to shape a bulk of composite around the splint. So as you can see in this figure, only that specific space or the rhomboid space you need to give a composite, and it has to be cured. Otherwise, if you're using a wire splint, every area, whichever area we have to, the large amount of space will be etched and bond, and then composite resin is placed and cured, and after that also you have to remove the excess of the material. So all these things are not required in a TTS. So on contrary, a thin layer of fluid or composite can be simply applied to fill the rhomboid opening with subsequent light curing. So it is a very easily applicable splinting technique, but the cost is a little more higher when compared to the conventional methods. So, use of antibiotics in traumatic dental injuries. So, a patient's medical status and concomitant injuries has to be considered when you are giving an antibiotics to the patient. Tetracycline is basically the first choice for 1 week after replantation, but since it is not considered in such conditions, we have to consider giving penicillin or penicillin 5 children under 12 years of age. That means your amoxicillin. So topically, you can prescribe giving the minocycline, doxycycline 1 milligram per 20 milliliter of saline for 5 minutes because it will increase the pulpal revascularization and periodontal healing. Tetanus toxoid is very important. The patient has to be referred to the physician. If avulsed tooth has any contact with the soil, or if the trauma has happened in a rusted area or in a dirty place, then if tetanus coverage of the patient is uncertain, you have to certainly give a booster dose to such patients. So what are the patient instructions you are supposed to give in case of avulsion injuries? Avoid participation. In future, after treating such avulsion injuries and reimplanting the tooth, you have to tell the patient to avoid participation in contact sports. They are recommended to have soft diet up to 2 weeks. Use soft toothbrush after each meal, and you can prescribe chlorhexidine mouth rinse, 0.1% chlorhexidine mouth rinse twice a day for 1 week. Something which is very important to be followed in such process or treatment plan is the endodontic consideration. So a follow-up procedure for a avulsed permanent teeth is required, which includes root canal therapy. If root canal treatment is indicated, teeth with closed apex, the ideal time to begin a treatment is around 7 to 10 days. So wherever you see the decision tree for a replanted tooth, you can see that every case is ideally it has to be root canal has to be initiated within the days 7 to 10 days post replantation. So calcium hydroxide is recommended for intracanal medications for up to 1 month, followed by root canal filling with root canal filling material. So initially medicament is placed and later the complete permanent restoration with the GP can be followed up in a tooth where the apex is closed. The tooth has been dry for more than 60 minutes before reimplantation. Root canal treatment is performed prior to replantation. So before replanting the tooth, we can consider giving restoring or do the RCT outside the socket, and then you can consider replanting within the socket. So teeth with open apices replanted immediately or kept in appropriate storage medium and pulp revascularization, and see if the pulp revascularization process is possible or not. Root canal treatment avoided unless there is a clinical and radiographic evidence of the pulp necrosis. So basically it can be avoided unless it is a pulp necrosis is present. So Anderson has studied in monkeys and found out that extraordinary embryonic treatment is better, and sorry, it's not better. That means more chances of ankylosis if you're doing extraordinary embryonic treatment. That means outside the cavity itself, after when you collect the tooth, if the dry time is more, it has been recommended that you can do embryonic treatment outside. That means extraordinary. But Anderson has already studied in animal studies. He had found out that there are more chances of ankylosis if you do that. So endodontic treatment is advised for around 1 to 2 weeks after, that means 7 to 10 days after replantation. Halt development of inflammatory resorption, and it allows the reformation of medial fibers. One of the major reasons for doing this is so that the remnant necrotic pulp tissues within the canal is avoided. So if there is presence of this necrotic tissue within the canal, there are more chances of inflammatory reaction within the cells. So to avoid that, endodontic treatment is proceeded. Cole et al. In 2005 said that replantation after retrograde insertion of the ceramic or titanium post is advocated. And when the teeth was validated around 31 months, they found out that there is less incidence of the inflammatory root resorption. That means the apex has been sealed. So in such conditions, if there is no uh, passage of these necrotic tissue or toxins within the canal to the outside, then that condition root resorption has been found to be formed very less when compared to the other incidents. So Sabas et al. In 2013 said that avulsed tooth replanted after prolonged extraoral time without transport media. So what he had done is he replanted a tooth which was having an extraoral dry time for more than 27 hours. That means it has exceeded the limit. So more possibilities of non-viable PDLs or dead PDL cells will be there. And what he did was in a 12-month follow-up, he did extraordinary embryonic treatment, and he had done a replantation of this tooth. And what he found was in the first few cases he had done this, and one of his case, it was found that intraocclusion had happened. That means 0.5 mm, the tooth is gone inside, and he saw some certain amount of mild replacement resorption in the second case. So despite extended extraoral time, some of the tooth has survived. The teeth may be replanted to maintain the surrounding bone. At least what he suggests is that in such conditions, what we are supposed to do is in whatever condition it is, place into the storage media for a time being, then try to replant it so that in case of even if it gets ankylosed, we can do other treatment procedure. Following an ankylosis, what are the other next treatment procedures to follow up? So based on that, you can maintain the integrity of the bone, and in future you can do the further treatment to correct aesthetic if it requires aesthetic corrections. So this is, as you can see in this picture, initially the tooth has been replanted and the splinting is. Once you replant, this is you can see is splinting done. Splinting is done. Then they'll take a radiograph and see. As you can see, there is a radiograph. He had done the endodontic treatment prior, and he had replanted to this tooth. So 18 months later, he saw that there is a slight infraposition. It has gone a little more inside when compared to that of the adjacent tooth. So as you can see, there is ankylosis. There is very less here. This side, it has already been fused. What is vital root submergence? Vital root submergence was introduced by Johnson and Jensen in 1997. So the root fragment is retained in situ and left vital. So here what they will do is, in such conditions, root fragments, whichever tooth which we have replanted, the root fragment will be retained in that bone, and then we will leave it vital. We just go beyond the periapex, provide bleeding within the canal, and we'll just seal it off. So gingival tissue is sutured over the exposed root stump to achieve primary closure. So initially primary closure is attained, and later the root is replaced by an implant. So in future you can proceed the treatment with placing an implant on top of this area. Not usually preferred in an aesthetically sensitive area. So this is not usually preferred in a place where it is which requires aesthetic consideration. That means an anterior tooth. So how do you evaluate a valved tooth? Like as we have said earlier, after replantation, what are the outcomes which you have to see? So favorable outcomes. So when you write an answer, also you have to mention about the favorable outcome and the unfavorable outcome. So what are the favorable outcome you will see in a closed apex condition and an open apex condition? So in a closed apex condition, it should be asymptomatic. Normal mobility should be present, normal percussion sound, no radiographic evidence of resorption or periradicular osteitis. The lamina dura should appear normal. Whereas in open apex case, it should be asymptomatic, normal mobility should be there, normal percussion sound, radiographic evidence of arrested or continued root formation and eruption should happen in an open apex condition. Whereas in an unfavorable outcome, closed apex cases, it will gradually show symptoms. It will become symptomatic, excessive mobility or no mobility. That means it is led to ankylosis with high pitched percussion sound. So here you have to note, on tenteron percussion you will hear high pitched percussion sound. Then radiographic evidence of resorption. That means it can occur inflammatory resorption or replacement resorption. Infection related resorption will happen in the unfavorable situations. So in an open apex, it should be in unfavorable situation. It will be symptomatic, excessive mobility or no mobility will be present with high-pitched percussion sound. Ankylosis means crown of the tooth appear to be in an infraocclusal position. That means it will go a little more inside when you look into the adjacent tooth, the previously replanted from the previously replanted position, you will see that it is gone. It will be gone little more inside, or it will look like a submerged version. So radiographic evidence of resorption such as inflammatory, infection-related resorption or replacement resorption will be found in an unfavorable situation. So to conclude, retaining a valve tooth in arch is very, very important, and even if the prognosis is poor, the first line of treatment should be your replantation of the avulse tooth. So even primary tooth can be replanted in cases if their child is very young and if there are no chances of eruption of the permanent successors any sooner. So in such condition also we can recommend replanting the primary tooth. So here we will discuss about the most important questions which you will get from this traumatic dental injury session. So Ellie's class 4, that is a non-vital condition, we will be discussing in another session. So today we will be discussing on the most commonly asked questions in this session, that is traumatic dental injuries. So one of the repetitive questions which have been asked is about discuss various classification of traumatic dental injuries to anterior teeth and discuss the management of at least class 3 fracture of an upper central incisor in an 8-year-old child. So from trauma, you have to expect such clinical oriented questions. Ellie's class 3 fracture, there won't be any direct questions like what is Ellie's class 3 fracture and write its management. You will get a question like this, some clinical scenario and you will be asked to write the management regarding that. Otherwise, you will get a question like this. Discuss the line of treatment of fractured to one of an 8-year-old child reporting immediately to the dental clinic with the exposure of the pulp. So as you can see here, they have mentioned the age of the child. From the age of the child, you have to assess whether in that time period, the uh, tooth of complaint, it would have a matured root or an immature root. Does it have a closed apex or an open apex? So based on that only you have to come up with the management. Traumatic management, what is the restorative management of such cases? So 2-1 and upper central incisors. So even upper central incisors are here 2-1. The possibility of this tooth to have a closed apex is very less. So for an 8-year-old, it might have recently erupted and there are more chances that it is an immature or an open apex tooth. So in such condition, you have to mention regarding if it is an immature tooth and it has to be uh, treated to close its apex, either apexification, pulpotomy procedures, epixogenesis based on the clinical scenario. So whenever you are writing, you have to write down what that particular fracture is, what are the clinical findings which you will see in that fracture, imaging, radiographic assessment and finding, then what is the recommended treatment for that fracture, what is the follow-up which has to be done, favorable outcome and the unfavorable outcome. So whenever you're asked to write the management or if you're asked to write about certain traumatic dental injuries based on Ellie's classification, you have to write the answer in such a way with clinical findings, imaging or radiographic findings, treatment, follow-up, favorable outcome and unfavorable outcome. So usual treatment modalities which you should be writing is pulp capping. So if the pulp exposure is more than that, you have to, if it is close approximating pulp and if the pulp is not exposed, you can recommend giving pulp capping. So if it is close approximating to pulp and if there is a pinpoint opening or a pinpoint exposure or if the trauma, the patient has come to you within 24 hours and all, you can recommend giving pulpotomy. But if the extent or the dry time is more means you have to give pulpectomy or if it is a bigger lesion, you have to give pulpectomy procedures. And in an immature tooth, apexification or apexogenesis based on the pulp exposure. And if it is not, if it is in a condition where it cannot be maintained, the final uh, treatment procedure or call will be for extraction. So this is ideally how the like final management, what you're supposed to write is this based on the clinical scenario. The next question which you might get is classify injuries of antiquity according to Ellis and Davies. So the first part, usually questions from trauma comes like this. The first part will be classification of the dental traumatic injuries, and then the second part will be a clinical scenario or they discuss the consequence of injuries to primary anterior teeth on the developing permanent teeth. So what happens if there is trauma to primary anterior teeth and what happens to the successors or the developing permanent teeth. So here are some of the points, effect of trauma on development of succedaneous tooth. This is a very important question. Whereas this has been discussed in the previous session. That is, you will get a white or yellow brown discoloration of the enamel because of the previous trauma. White or yellow brown discoloration of enamel and horizontal enamel hypoplasia. Change in the position of the developing tooth, but possibilities of having crown dilacerations, odontum-like malformations, root duplication might occur, vestibular root angulation, lateral root angulation or dilaceration, partial or complete arrest of root formation, sequestration of the entire tooth germ might happen, eruption disturbances will also happen. So these are the consequences of a trauma onto a primary tooth or a deciduous tooth and the effect of trauma onto the permanent or succedaneous teeth. So these are the points which you should write when they ask you such questions. So next, some of the questions which you might get from this chapter is measures for stabilization of avulsed teeth. Measures for stabilization of avulsed teeth means splinting. So you might not get a question like directly like what is splinting or write about splinting, discuss in detail about splinting. So if you are asked to write about measures for stabilization of avulsed tooth, you are supposed to write splinting. Then you can write about Turner's hyperplasia. Turner's hyperplasia, as we have told you, white or yellow brown discoloration of the enamel, or any eruption disturbances. So in such conditions, if the trauma has happened to a deciduous tooth, there are possibilities enamel hyperplasia will be seen in the succedaneous tooth or successors. That is what we call it as Turner's hyperplasia. Discuss the management of avulsed permanent central incisors in a 9-year-old child, and write about storage medium. Storage medium, you have to write about HBSs, milk, then coconut water. Recently advanced storage mediums you have to write. Then in case if you can study about the organ transplant mediums like Biospan or MEM and all, you can write that. So when you're writing about storage medium, if possible, you have to learn what is the pH of this particular storage medium and what is the osmolality levels of that particular storage medium, whichever storage medium. And when you're asked to write about storage medium, write what is storage medium. Then you have to write what are the ideal properties a storage medium should have, and write some of the 3 or 4 examples for storage medium, like milk, HBSs, Biospan, and coconut water or urocolins or whichever 4 easiest storage medium, please study. But you should never miss milk and HBSs. So properties of an ideal splint, we have already discussed in today's session. Then there are different kinds of splints used: wire and resin splint, acid edge composite resin, orthodontic brackets and wire splints are there, interdental wiring, fiber splint. Fiber splint is the most advanced and most acceptable fiber splint which is used nowadays. Then you have the titanium trauma splint. Next Viva question, or an important question which you may get, is the reaction of the pulp to trauma or sequelae of the pulp to dental trauma. So this can be seen in, I think this is properly given in McDonald. So the proper staging goes like this: pulpal hyperemia, internal hemorrhage, calcium metamorphosis of the dental pulp, internal resorption, external root resorption, pulpal necrosis, and ankylosis. This is the reaction of pulp to trauma. So if you are asked to answer about reaction of pulp to trauma, this is what you are supposed to write. Next is prevention of trauma during contact sports. So rarely you might get questions from this. So here what you are supposed to do is initially to prevent, orthodontic correction of the trauma prone profile has to be done. So in case if the child has a proclined anteriors and if there is no lip competency, so if the child is playing or doing any sport activity, possibilities of like trauma, like child had tendency to fall, there are more tendency to fall. So in such condition, if the tooth is proclined, more chances of trauma to the anterior tooth. So otherwise, you have to use a face guard or mouth protectors to avoid this dental trauma. Next session is about face and mouth guards. What are face and mouth guards? What are the ideal requirements of a mouth protector? So it should be of adequate thickness to reduce impact of trauma on the tooth. It should have good fit, should not fall off from the mouth during the activity nor be very tight. It should not interfere with the speech and breathing. Materials used must be non-allergic. So basically 3 types of mouth protectors are available. Type 1 is a stock type, type 2 is mouth form, type 3 is custom fabricated. So usually mouth guards and face and mouth guards are commonly asked as short notes. At least if you write ideal requirements and what are the types of mouth protectors used, you can write that. Thank you so much. So here we will end with the avulsion, traumatic dental injuries part 1. Next session will be your management of the non-vital tooth which is caused due to trauma.